cost of ORS is also very low, and the buying capacity of most of the people in developing countries, they can afford. Okay? So how we are going to prepare and administer ORS? It is, you need to wash your hands. We have commercially available sachets. We have available sachets now. So ORS के sachet हैं. In a clean container, you need to put the ORS powder. Please do not talk behind. Okay, so we need to. This is something which is very basic. If you do it, you can save life. So बहुत सारे ऐसे I have seen professionals who ORS prepare नहीं करना आता है. We have to learn it. Simple है, basic है, but still you need to learn. So ORS powder you need to put in the clean container. 1 liter of clean drinking water you need to put it and mix it well till the powder disappears. You need to mix it, and then you have to give this ORS to the child who is affected, and the prepared solution can be given till 24 hours, and then you need to change it. Okay? Next. Okay. The amount is up to 2 months, 5 teaspoons after each loose stool, 2 months to 2 years, 1/4 or half glass, 2 years to 10 years, half cup to 1 glass, and over 10 years, as much as the child takes. Okay? Next. Apart from this, zinc supplements are given, and in few cases, antibiotics is also prescribed if the child is having blood in stool or some other comorbid conditions or other super infections are there, like pneumonia, ear infection, urine infection, apart from diarrhea. Then antibiotics are also given. Okay. Now, the role of nurse is in educating the caregiver, the mother, regarding prevention and home management of diarrhea. That is how she is going to prepare the ORS. Then, apart from ORS, she should continue breastfeeding if the child is on breastfeeds. Then the other homemade available fluids, what you can suggest as a nurse is rice or what we say is chawal ka pani, dal ka pani, ya curd. Then shikanji, a lemon drink is there, coconut water is there, and even plain water can be given to the child suffering from diarrhea. Then we need to tell the caregivers for personal hygiene and food hygiene. Also, we need to educate them regarding vaccination. So we all know that preventive vaccination of diarrhea, that is rotavirus vaccination, is available, right? And it is given, it is included in our vaccination immunization schedule, that is 6, 10, 14 weeks, and it is also given up till 1 year of age. So if in case you come across any child who is less than 1 year of age not given rotavirus, you can educate the parents that till 1 year of age the vaccination is given orally. Okay? Then also identification of danger signs. So what I told in the previous slides, we have around 10 to 15 signs and symptoms or clinical features, but we do have danger signs which we need to identify. We need to tell to the parents, और वही लोग जो हैं identify करके they should bring the child as early as possible from home to the health facility. Change. Okay. So now the second part is the surgical condition. What I am going to discuss is the anomalies which are related to oral cavity. So oral cavity, we have cleft lip and palate. Have you ever seen a child with cleft lip and palate? देखा है किसी ने? So specific characteristic features are there for cleft lip and palate. So cleft lip आप image में देख सकते हैं. Cleft lip is characterized by fissure or opening in the upper lip, right? And how it is happening? it results with the failure of embryonic structures of phase to unite. So इसीलिए I have initially told you the embryology, है ना? So this is happening because of failure of embryonic structure to unite, and the fissure may be unilateral. In the first photograph, you can see bilateral cleft lip, and that is the normal palate which has united. Then coming to cleft palate, it is midline fissure of the palate that results from failure of fusion of the tissues which forms the palate. And we have hard palate, soft palate. It can involve both. Okay? Then assessment. So on receiving the baby, जब आप receive कर रहे हैं right after delivery, this can be identified. Why? Because the child will be having defective loop, है ना? Cleft lip or palate you can identify right after birth on assessment. The child will be having defective loop, then difficulty in sucking and swallowing, defective dentition, and difficulty in speech later on. Change. Treatment and nursing care. So initial treatment is surgical repair of lip. If the child is suffering from lip, the lip repair is done. If the child is having palate, the repair is done for palate and either both. Third month, left lip repair is done, and ninth month, left palate repair is there. Now nursing care includes, it is prevention of infection. You need to tell the parents. Provision of adequate nutrition. So here you can see a specialized instrument or a specialized bottle, feeding bottle, that is known as Haberman's feeder. This is something very unique. It is created only for cleft lip and palate kids, so that they are able to suck easily. Okay? Then prevention of aspiration. Common complication is there, that is aspiration. Parent education includes home care of the child, and we need to provide the pre-operative and post-operative care. Apart from all these, divergent therapy is must for a child. Why? Because post-operatively, the repair is done for both lip and palate, and if the child cries out of pain or anxiety, will be difficult. So, diversion therapy is required in these type of cases. Next. Second surgical condition is anomalies which are related to esophagus and stomach. So here I am going to discuss esophageal atresia and TEF, that is tracheoesophageal fistula, which is the commonest anomaly of esophagus. Now, what do you mean by esophageal atresia? Atresia is something narrowing. Okay. So esophagus, it is related to esophagus. So esophageal atresia, it is complete interruption of continuity of esophagus to stomach. Okay. Esophagus connect to stomach. So it is interruption in that continuity. Then tracheoesophageal fistula, it is congenital abnormal connection between proximal or distal esophagus and trachea, and these both, the esophageal atresia and TEF, sometimes they occur with or without TEF. Okay? So in this image, you can see this is the first one is the normal anatomical structure, where the trachea, you can see tracheal rings, and then it is bifurcating in both the lungs. Continuation is there. The yellow part is the esophagus, and it is connecting to the stomach. Now we have types of tracheoesophageal fistula. You can appreciate type A is atresia. The proximal and distal ends of the esophagus, they have blind pouches. Connection नहीं है ना? Second way, you will see the proximal part is attached to trachea. C type, the distal part is attached. D type, double fistula is there. The proximal and distal part both are attaching to trachea. And then the E type is the fistula one. So these are the commonest types of tracheoesophageal fistula. Next, coming to management and nursing care. So these kids, the newborns, they will be presenting with excessive salivation and drooling of saliva from the mouth, and because of this saliva, excessive drooling of saliva, they can even choke. Okay? So coughing occurs, gagging occurs, choking occurs, and sometimes even cyanosis occurs at the time of first feed. Then aspiration pneumonia is also common in these children. Diagnostic evaluation is passing a radio opaque catheter into the stomach and explain X-ray of abdomen which shows gas in the stomach. So these types of so a child or a newborn suffering from TEF requires surgical management. Okay? So as and when on priority basis, we have to prepare the newborn for surgery. Surgical management requires primary repair, which involves the end-to-end anastomosis. So, anybody can tell me what is end-to-end anastomosis? What we are talking about? अभी हम हाँ बताइए.
End-to-end कट करके उसको कनेक्ट कर देते हैं राइट में.
Very good. Very simple answer. So, you all know that if the blind pouches are there, तो उसको क्या करना है? Continuity maintain करनी है. So what we are going to do is we are going to connect it anastomosis करके. So it is primary repair which includes end-to-end anastomosis, that is proximal and distal end को connect करना है. And if the baby is clinically not fit, if the baby is clinically not fit, why? If the baby is having pneumonia or less weight at the time of birth, low birth weight, then at that particular moment, gastrostomy is done